So when a patient is on frontline therapy, whether it's monotherapy or combination therapy, we really need to make some decisions about when is the best time to move on to another agent or combination of agents. And my practical guidelines here would really say that if you have relatively slow growth of existing lesions and the patient's asymptomatic and you don't see really any threat from any of these lesions in the immediate horizon, they can continue on this regimen. If you have 15 or 20% increase in tumor diameter, but the patient's doing very well, I think that they can continue on this regimen. But if you see that an individual then starts developing new sites of metastatic disease and or are starting to develop symptoms and or you're really seeing a decline in their overall physical state, then I would say it's time to move on to another regimen.
One of my favorite things about treating patients with kidney cancer is that they often do well with multiple different lines of therapy. I think in the past it used to be a paradigm where patients only got 1 or 2 cracks at treatment and then you were lucky if you got them to a third. I think what we're seeing now in this era of very effective therapy is patients are living much longer, they're living better, and they're also seeing multiple lines of therapy. The problem is the frontline setting is moving so quickly, we don't know how to adjust our second line approach based on that. We can't do the trials fast enough. So right now, the paradigm I use is what we know and what we don't know. What we know is that sequential VEGF inhibition can have benefit. We've proven that in multiple trials before the immunotherapy era. What we don't know is whether sequential pure immunotherapies can work. And some of these data are coming out, and I don't think we're going to see as much efficacy in second-line immunotherapy after a patient has progressed on their first-line immunotherapy. So I think for now in my practice, I lean heavily on the VEGF inhibitors after frontline if a patient's progressed. Again, which one I select depends on what's available, what trials are available, what the data is that day, but also how they did on their prior therapy, both in terms of how they tolerated it and how well it worked on their cancer.
So one of the questions that we frequently get asked is whether or not there's some sort of a mechanistic rationale based on the MOA of agents in terms of sequencing. And I think that's really somewhat challenging because of the fact that we have IO MOA, so we're modulating the tumor microenvironment by enabling effector T cells, or we're modulating the angiogenic features of the tumor, and we're basically doing some vascular remodeling. What's pretty evident is that when you start with an IO agent and then they start progressing and you move on to a TKI, we've seen, and we have anecdotal data which are published as well as small phase 2 studies which have been published demonstrating that you get a remarkable response to TKI therapy after IO therapy in a subset of individuals. So it's almost like the microenvironment has been preconditioned by the IO therapy, which then results in a more robust response to TKI therapy. Whether or not starting, for example, with axitinib plus pembrolizumab, where you've got a very focused VEGF receptor blocking agent together with IO therapy, whether then moving on to, I would call it a more complex and more sophisticated VEGF TKI like cabozantinib or lenvatinib, whether that then really is going to enable and rescue some resistance with the additional factors that are blocked, really I think is a question that's going to be answered with some studies that are going to be coming out in the next year or two.
I often hear kidney cancer referred to as a crowded space. There are lots of agents in kidney cancer, and we love that. We love having options for patients, but we still haven't cured the disease, and we still don't have all the answers, and we still really are leaning on 3 different mechanisms of action: VEGF inhibition, mTOR inhibition, and immunotherapy. I think it's really important that we continue drug development in this disease, that we find new agents targeting new aspects of the cancer, test them alone and in combination. And to that end, we really need the courageous patients in our clinics to enroll in clinical trials to test these new therapies. All of the developments we've made have been through the courage of generations of kidney cancer patients before who have taken a chance and enrolled on a trial. And many of those patients actually benefited from their participation in the trial. But certainly as a community, we all benefited from their participation. So we're grateful to them, and we want to continue to move forward, find new treatments until we have a cure.